let me welcome all of you to this exciting webinar which we have planned today. So before I go ahead with this webinar, let me wish you all a very happy Durga Puja. May Goddess gives us strength, wisdom, and happiness, and eradicate the pandemic which is currently going on. So here we are yet again at the very exciting webinar. There are two topics in the webinar, and both the topics are correlated to each other, we can say. And we have a very exciting set of panel here. So without wasting any time, let me introduce today's moderator first. So we have today Dr. Spandan Bhadury. Sir is MD Medicine and DM in Cardiology. Sir has been international cardiologist, professor of medicine at North Bengal Medical College, Siliguri. Sir has a rich experience of 25 years in the field of cardiology. Sir has worked with reputed institute in the eastern part of the country like Medical College, Calcutta, BS Medical College, Arita Medical College. He has conducted many cardiodiabetic camps over the duration of 2 decades. Sir has published various papers in various national and international index journals. Sir has also written nevertheless, sir has chaired many academic events as a panelist, faculty, as a speaker to various academic events which happen nationally and internationally also. He's a very popular teacher and academician. Moreover, in his current scenario, sir has been a national level trainer of trainers on COVID-19 by Government of India. So welcome Spandan Bhadury sir on behalf of everyone.
Thank you very much.
Yeah. Now moving towards the speaker which we have today with us, we have a very eminent speaker today, Dr. Arita Konar. Sir is MD in medicine and he has done DM in cardiology. Sir has been consultant interventional cardiologist to Apollo Gleneagles Hospital, Calcutta. In his previous assignment, he was associated with Anand Loke Hospital, Siliguri as a consultant interventional cardiologist. Sir has an excellent procedural skills to various cardiac procedure. If you see the CV, the immense number of procedures that sir has performed. He has performed several procedures as a primary operator since last 5 years. And sir has various international publication on his name as well. He's author in CSI Update 2015 and he keep writing and contributing to various books in the field of cardiology. Has a research experience since 2011. Last but not the least, sir had a very instrumental role in CSI heart failure registry, which was done in the year 2018 and 90. So I welcome Dr. Arita Konar sir. Sir will be talking on the topic which is antiplatelet therapy in PCI. So probably he will be giving his expert opinion on the antiplatelet therapy for primary coronary intervention. Moving towards another speaker, Dr. Arindam Naskar sir. Sir is MD Medicine, MRCP UK, and he has done CCEBDM diabetes. Sir is consultant physician and diabetologist in charge Department of Metabolic and Nutritional Disease School of Tropical Medicine, Calcutta Medical College. He has been associated with Chelsea and Westminster Hospital, NHS Foundation Trust, Fulham, London. He is a member of Royal College of Physicians, UK in 2016. He got GMC registration from UK in 2018. And sir is expert in metabolic and nutritional disease and tropical medicine. Sir will be giving his insights on triple therapy in hypertension management. So I welcome all the moderators and all the speakers for this exciting event. And now I hand over the session to our eminent moderator, Spandan Bhadury sir. Please, sir.
Yeah, thank you for kind introduction of me and our speakers in this evening. We have two important topics to deal with by two eminent speakers. First, we should, as I have already told, we should deal with hypertension first, because hypertension is a really global epidemic problem. More or less, nearly 1.5 billion of people are suffering from it, and more than 10 million deaths occur directly due to hypertension-related cardiovascular diseases. So its control is really a problem. And we have with us Dr. Arindam Naskar. I'm confident that he will ably, nicely deal with this topic, and we'll have discussion after his talk is over. Over to Dr. Naskar, please.
Yeah. Good evening, Dr. Bhadury and Dr. Konar, and also Prakash. Today, I'm really honored to be invited as a speaker in this topic. So I'm starting my topic. So my topic is triple therapy in hypertension. So hypertension is a triple paradox. It's very easy to diagnose, but often remains undetected. Simple to treat, but often remains untreated. As well as despite availability of potent drugs, often treatment with all is ineffective. And as Dr. Bhadury told already, an estimated 1.13 billion people worldwide have hypertension. And in India, it's more than 20 million people they're suffering from hypertension. So what is hypertension? Is a very basic science we have been told, we have been taught in our undergraduate days, that hypertension is also known as high or raised blood pressure. Is a condition in which the blood vessels have persistently raised pressure. That is called hypertension. Next slide, please. So, how to measure blood pressure? The ideal background should be the back should be supported. No talking during and between measurements of blood pressure. Cup to feet arm size. Also, the patient or the person should be in quiet room, comfortable temperature. No smoking, coffee, or exercise for last 30 minutes. Relax for 3 to 5 minutes. Take 3 measurements at 1 minute intervals and use the average of the last 2 measurements. And the machine, the electronic blood pressure machine should be validated. That is very important. There is a website, it's www.stridebp.org. You can check the validated digital blood pressure machines over there. So this, what are the mechanisms of hypertension? Hypertension or arterial pressure, they are mainly dependent on 2 factors, like cardiac output and peripheral resistance. Cardiac output is determined by stroke volume and heart rate, where the stroke volume is related to myocardial contractility and to the size of the vascular component. This is a very basic physiology. And the peripheral resistance. Peripheral resistance is determined by functional and anatomic changes in small arteries. So, arterial pressure is mostly dependent on cardiac output and peripheral resistance. Cardiac output depends on stroke volume, heart rate, and peripheral resistance depends on vascular structure and function. That is the mechanism of hypertension. So this is the hypertension classification by ESC 2018. They have graded hypertension. And what is grade 1 hypertension? When the blood pressure is more than 140, and 140 to 159 is systolic BP, and the diastolic BP is 90 to 99. That is called grade 1 hypertension. And grade 2 is if the blood pressure is systolic BP is 160 to 179 and diastolic BP is 100 to 109. Grade 3 is more than or equal to 180 systolic blood pressure and diastolic blood pressure is more than equal to 110. What is isolated systolic hypertension? The systolic blood pressure is more than 140, but the diastolic pressure is less than 90. So that is the hypertension classification. So now, what is masked hypertension? Masked hypertension is defined as the clinic blood pressure measurements are normal, that is less than 140 by 90. But blood pressure measurements are higher when taken outside the clinic, like in ambulatory blood pressure monitoring or in home monitoring of blood pressure. Whether white coat effect. White coat effect is a discrepancy of more than 20 systolic by 10 diastolic blood pressure between clinic and average daytime ambulatory blood pressure monitoring or home blood pressure monitoring pressure at the time of diagnosis. Now, hypertension definitions according to office, ambulatory blood pressure monitoring and home blood pressure monitoring. Office blood pressure, I already mentioned, the systolic blood pressure should be more than 40 and diastolic blood pressure should be more than equal to 90. Whether to call a hypertension, the ambulatory blood pressure should be, systolic blood pressure should be more than 135 and diastolic is more than equal to 85 when the patient is awake or daytime. And when the patient is asleep, the systolic blood pressure should be more than 120 and diastolic more than 70. As well as home blood pressure monitoring, the same for ambulatory blood pressure monitoring. It's the same range. We'll call hypertension when the systolic blood pressure is more than 135 and the diastolic pressure is more than 85. So what is ambulatory blood pressure monitoring? You can see the picture where you can see the machine is attached with the belt and the cuff is tied at the arm, upper arm. So the ambulatory blood pressure measured over 24 hours, mostly in the awake time from 8 AM to 10 PM. And at least 2 measurements should be done in 1 hour. And average of minimum 14 readings should be checked, and then the average reading is the mean blood pressure level. That is the concept of ambulatory blood pressure monitoring. But whenever there is inconvenient of doing ambulatory blood pressure monitoring, one can check home blood pressure monitoring twice daily, one in morning, one in evening. Usually twice blood pressure should be checked. Morning, evening, twice sample. One after the second, like the blood pressure should be checked twice in morning, twice in evening. That is the home blood pressure monitoring. And the average should be done for 5 to 7 days, and then the average blood pressure should be measured as home blood pressure measurement. Next slide, please. So hypertension. What is hypertension? Hypertension can be due to different factors, a multifactorial entity. That may be due to some genetic factors, some environmental factors, as well as some different systems or mechanisms that are associated with hypertension. The most important thing is RAS, renin-angiotensin-aldosterone system, where renin produced from juxtaglomerular cells, it converts angiotensinogen to angiotensin 1. And angiotensin converting enzyme, they convert angiotensin 1 to angiotensin 2, which causes vasoconstriction, and then they secrete aldosterone also. There is sodium retention and vasoconstriction, but by that, blood pressure is raised. Second mechanism is natriuretic peptides. It reduces blood pressure. It's the arterial natriuretic peptides. They maintain sodium balance and blood pressure during sodium loading because natriuresis and vasodilatation. So it reduces blood pressure. And the role of endothelial system, some different vasoactive substances are there. There is nitric oxide that can cause vasodilatation, that reduces blood pressure, and endothelin causes increased blood pressure. Another important system is sympathetic nervous system. When there is activation of sympathetic nervous system, there is release of catecholamines, increased renal sympathetic activity, increased sodium ability, and there is increased blood pressure. Next slide, please. So today there is no simple way of predicting which patients will respond to which class of antihypertensive drugs. I already mentioned there are different factors like sympathetic nervous system, RAS system, vasculature, genetics, environment, as well as hyperinsulinemia or insulin resistance that can also stimulate sympathetic nervous system and increase renal sodium retention. So these are which factors they are influencing cardiovascular risk in hypertension. There are certain parameters. You can see the sex, men are more vulnerable than women, age, smoking, total cholesterol, HDL, uric acid, whether the patient is diabetic or not, patient is overweight or obesity. If there is a family history of premature cardiovascular death, in case of men, it's less than 55 years. In case of women, it's less than 65 years. Early onset menopause, sedentary lifestyle, that is also very important. Psychosocial, socioeconomic factors, and the base heart rate level more than 80. So these are the factors they can influence cardiovascular risk in hypertension. There are different scores like cardiovascular risk scores developed by European Society of Cardiology, like SCORE system, Q risk 2 system, and also ACE-CBD system scores. So when a hypertensive patient, when a patient is diagnosed as hypertensive, what routine investigations we must send? The routine blood test, we should send the sodium, potassium levels, the blood electrolytes, the creatinine, estimated glomerular filtration rate or EGFR, lipid profile, and fasting glucose. We should send the urine sample for urine dipstick test to look for proteinuria and hematuria. And 12-lead ECG, a baseline 12-lead ECG should be done to detect any presence of left ventricular hypertrophy, any ischemic heart disease, or any detection of atrial fibrillation. So that should be done when a patient is diagnosed as hypertension. And the additional diagnostic tests. We should not do each and every patient's this one, but these are the additional diagnostic tests. We have to rule out whether this patient is suffering from any hypertensive related organ damage. So we can do fundoscopy for retinal image, retinal changes, retinal papilloedema, hemorrhage, tortuous nipping. Also, the kidney and renal artery imaging, particularly when we are suspecting any secondary hypertension. When the young aged hypertension, we should do renal artery Doppler, CTM, and angiography, rule out renal parenchymal disease, renal stenosis. Carotid ultrasound, patient that suffered from TIA or stroke, and echocardiography. And the functional tests like ABPI, and the further investigation depending on the cause of hypertension. We can say the plasma free beta nephrin aldosterone ratio, and I already mentioned that urinary albumin creatine ratio. So depending on the patient's situation, we have to manage this test accordingly. Next slide, please. So what may be the damage of hypertension? The different organ system, they are damaged by hypertension. It can cause stroke, like CBA, like brain hemorrhage, infarction. Cardiovascular, it can cause acute coronary syndrome like myocardial infarction, heart failure. It can cause CKD, chronic kidney disease. It can cause hypertensive retinopathy, and it can cause peripheral arterial disease. So these are the major organ system that can be damaged by hypertension. So whenever a patient has been diagnosed as hypertension, we have to look very carefully whether this patient is suffering from any hypertension mediated organ damage or not. Next slide, please. So what are the factors that contributing to uncontrolled hypertension? There are different factors. First one is non-adherence. This very important factor is non-adherence to prescribed treatment. Sometimes there are lots of medications. A hypertensive patient, they are associated dyslipidemia, diabetes. So polyphenol is a important factor. So the adherence. Also, the patient is taking lots of anti-hypertensive medications, dual or triple medications. So that is very important. Second factor, I already mentioned the multiple mechanisms in the pathology of hypertension. Therapeutic failure with monotherapy dose titration. And number 4, underuse of drug combination strategies. So these are the factors that are contributing to uncontrolled hypertension. Why hypertensive patients do not adhere to the treatment? So we have to consider first, what are the main factors the patient is not adhered to treatment. Medication, I already mentioned in my previous slide, that more than 1 in 24 hours. Also the side effects of medications. Different hypertension medications have different side effects, like the calcium channel blocker can cause pedal swelling. Lots of patients come with pedal swelling also. This is the example. And patients' attitude towards hypertension and drugs. Most important thing is less awareness about treatment. Many patients we have seen in our day-to-day practice, they stop treatment when they are normotensive. Suppose the doctor has told him that now your blood pressure is normal, he has stopped treatment. So that is very important. Patient must be aware of his or her condition, that hypertensive patient should not stop drug treatment. He has to continue with the treatment. Knowledge taken from sources other than physician, and from physician perspective, sometimes when there is huge number of patients, especially in hospital OPD settings, there is short time of consultation. Number 2, information provided on request from the patient. Number 3 is difficult to understand language. Sometimes there are from other languages patients, like Hindi language, other languages sometimes, but we have to be very careful and counsel the patient that you have to continue medications. And fourth and the most important thing is disease characteristics. The disease is chronic and patient may be asymptomatic if he or she is still hypertensive. So we need to consider these factors. Next slide, please. The therapeutic failure with monotherapy, dose titration. Sometimes what we do, we increase the dose of monotherapy instead of adding a second group of antihypertensive drugs. Then increase in what happened, uncontrolled blood pressure, increased dose of monotherapy, doubling the dose, there is increased incidence of adverse events and non-adherence to therapy. So side effect is very important. Next. So underuse of drug combination strategies. Clinical inertia. Sometimes it's a failure to initiate or intensify therapy when indicated. Sometimes we don't use the second therapy. We change the medications, double the dose. So factors contributing to clinical inertia. Sometimes there may be a lack of knowledge of guidelines. There are lots of guidelines, so sometimes maybe lack of due to the huge, like the different practice schedule. We often miss the different guidelines. Disagreement with known guidelines. Sometimes the physician has his own perspective that I should not do this treatment, I have to continue this treatment. Sometimes this personal perspective. Number 3, clinician's own clinical judgment and clinician's awareness of patient attitude, behavior, and preferences. 75% of hypertensive patients require the combination therapy to reduce blood pressure. That is very important. Next slide, please. So the conception of initial combination therapy is not new. It has been started in late 1960s. The Veteran Affairs Cooperative Study in 1960 showed reduced morbidity with improved blood pressure control using triple therapy combinations. They used triple therapy like hydrolazine, riserpine, and hydrochlorothiazide. And this slide is showing the historical evolution of fixed dose combination agents, starting from 1960, riserpine, hydrolazine, hydrochlorothiazide. In 1970s is thiazide with potassium sparing diuretic, as spironolactone, beta blocker with thiazide. In 1980s, AC inhibitor with thiazide. 1990s decades, low dose beta blocker, low dose thiazide, AC, CCB. And in 2020, it's ARB inhibitor, ARB, CCB diuretic. So these are the historical evolution of fixed dose combination agents. I'm not going details into that. Next slide, please. So what are the basics of dual therapy? There is complementary mechanism of action, translates to better blood pressure reduction and lesser side effects. Better blood pressure reduction by synergistic effects, because different antihypertensive drugs, they act by different mechanisms, and the lesser side effects. Like diuretic, when we use diuretic with ARB, there is a reduce the incidence of hypokalemia. When you use calcium channel blocker with ARB, there is reduce the incidence of edema. So that is very important. Side effects are less. And this is a study, a meta-analysis of 42 trials. They showed that in 10,968 patients, that there is 5-fold greater blood pressure reduction with combination therapy than doubling the dose of single drug, like thiazide, beta blocker, AC inhibitor, calcium channel blocker, all classes drugs. So there is 5-fold greater blood pressure reduction in combination therapy. And also there is less incidence of adverse side effects compared to monotherapy. Next slide, please. And there is early blood pressure reduction, faster achievement of target BP. When you use combination therapy from the very beginning, 50% of patients, they have achieved target in 9 months. While the patients who are added the therapy, first they started monotherapy. After that, when they started the next therapy, the added therapy, 50% patients, they achieved the target blood pressure in 12 months. So there is 3 months gap. So there is faster achievement of target blood pressure reduction. That is very important. So patients spend less time in high risk state. As we know that As long as patient is hypertensive, there is more chance of developing hypertensive heart disease, heart failure, and there is risk of cerebrovascular accident. Definitely. So next slide, please. So better cardiovascular risk reduction. Starting and continuing antihypertensive therapy with a drug combination is associated with a 26% cardiovascular risk reduction, which is very important. So what should be the ideal choice in patients with comorbidities? Monotherapy for the control of hypertension is not likely to be successful in hypertensive patients, especially with comorbidities like heart failure, type 2 diabetes mellitus, because these patients we have seen in follow-up, second or third antihypertensive should be added to control the hypertension. So to achieve the recommended blood pressure goals, typically they require at least 2 or more medications. So these are the different guidelines recommendation from in 2013. The Indian guidelines, they suggested combinations should be used to reduce side effects and achieve goal blood pressure. And 2017 Canadian guidelines, they also showed their favor combination hypertension therapy, antihypertensive therapy. In 2017 ACC guideline also for adults with stage 2 hypertension and also with stage 1 hypertension with comorbidities, they suggested combination therapy. And latest the ESC 2018 guideline, they suggest initial therapy with combination antihypertensive therapy. Next slide, please. So these are the few major outcome trials that have utilized combination therapy to achieve and maintain target blood pressure levels. I'm not going into details of these. So these are the like ARCS trial, MDRD trial, ABCD trial. These are the different major outcome trials. They have shown that there are like you can see the slide that almost most of the trials they showed more than 3 antihypertensive therapy to maintain the target blood pressure levels. Next slide, please. So is it a necessity to start combination therapy in hypertension or combination therapy in hypertension? Is complementary mode of action, I already mentioned that, better blood pressure reduction, lower incidence of drug-related side effects, ideal therapy in patients with comorbidity, patient spends less time in high-risk state, improvement in adherence, because if we use 2 or 3 antihypertensive therapy in a separate pill, patient sometimes stop all the drugs. So if you use a fixed dose pill comprising 2 or 3 antihypertensive medications, the adherence is good, improvement in adherence. And also the guideline recommendation and proven in landmark trials. Next slide, please. So I've mentioned in my previous slide already that monotherapy, 75% patients of hypertensive patients, they require combination therapy. While 25% patients of all treated hypertensive who are on dual antihypertensive therapy, they require third antihypertensive therapy. They require triple therapy, 25% of the patients. So dual combination with one drug, triple drug single pill combination should be the ideal choice when the patient requires triple therapy. Next slide, please. As per ESC 2018 guideline, the initial dual combination recommendation is there unless the patient is more than 80 years of age and very low risk hypertension. Low risk means patient has cardiovascular morbidity mortality low. I already mentioned in my previous slides the different CV mortality factors like smoking, premature cardiovascular death, diabetes, other factors like diabetes, heart failure. These are all cardiovascular factors. Also, there is hypertension mediated organ damage. That patient should be ideally started with combination therapy. Only patients with grade 1 hypertension with low risk and elderly frail patient, more than 80 years patient, they should be on single therapy. Next step 2 is triple combination. When the patient is not responding with AC, ARB or CCB combination therapy, then the diuretic of choice is diuretic plus calcium channel blocker, AC or ARB. That is the triple combination of choice. Step 3 is resistant hypertension. You should add spironolactone when the patient is not responding to this therapy. But remember one thing, if the patient is having CKD, if the EGFR is less than 30, then in place of hydrochlorothiazide or chlorthalidone, we have to use loop diuretic, because we have to keep in mind that in CKD patients. Next. So I have already mentioned the triple combination therapy, ARB or calcium channel blocker, thiazide diuretic. The calcium channel blockers, they activate the sympathetic nervous system, RAS system, thyroid also. So the combination of ARB, calcium channel blocker, and thiazide type diuretic is the ideal combination of therapy. Next slide, please. So the pharmacodynamic rationally, amlodipine or calcium channel blocker, they block the calcium channels, causes vasodilation, reduces peripheral vascular resistance, decrease blood pressure. ARB, angiotensin blocker, they cause vasodilation, decrease peripheral resistance, decrease blood pressure. Diuretics like chlorthalidone or hydrochlorothiazide, they causes diuresis, and later cause vasodilation, decrease plasma volume, peripheral vascular resistance, decrease blood pressure. So these are the combination of triple therapy, the mechanism. Next slide, please. And this is I'm not going through details of this pharmacokinetics. Personally, you all know the basic physiology. Only is the half-life is more in chlorthalidone than hydrochlorothiazide. Half-life of chlorthalidone is 40 to 60 hours, while hydrochlorothiazide is 5 to 14.8 hours. So the half-life in half-line basis, the chlorthalidone is more potent, slightly more potent than hydrochlorothiazide. And Temisartan Amlodipine, already mentioned. Next slide, please. So the efficacy of triple combination therapy. So the efficacy of triple combination therapy. Next slide, please. So this is a Japanese study. They showed that addition of diuretic to ARB or calcium channel blocker, they showed better systolic blood pressure and diastolic blood pressure reduction. Also, you can see in the right-hand slide, the graph, 52% patient achieved target BP, while the dual therapy with ARB CCB, in comparison to dual therapy, they achieved blood pressure in 24.8%. So more than double patients achieve target BP when we combine diuretic to calcium channel blocker with ARB. Next slide, please. And this is a trial called TRAN trial. It has been shown that there is they try to put the efficacy of triple antihypertensive therapy for amlodipine, telmisartan, and chlorthalidone. It's been done in 11 centers in Sri Lanka. It was a randomized control trial funded by Australian National Health and Medical Research Council. Next slide, please. First, they started with low dose telmisartan, amlodipine, and hydrochlorothiazide. Later, they changed to chlorthalidone because of that time the SPRINT trial published. So their mean baseline blood pressure was 154/90. They started lower therapy of telmisartan 20 milligram, amlodipine 2.5 milligram, and hydrochlorothiazide 6.25. Later, that study changed to chlorthalidone. Next slide, please. So I have just because of data generated by SPRINT trial, they changed to chlorthalidone. Next slide, please. They used the combination therapy of telmisartan 20 milligram, amlodipine 2.5 milligram, and chlorthalidone 12.5 milligram. And the trial design was 700 patients. Mean blood pressure was 154/90 millimeter BP. And there are two groups. 349 patients were started on triple therapy, fixed dose combinations, while the 351 patients, they were remained in the usual therapy. So the trial design and the trial was done, the patients were observed for 6 months. The primary outcome to check the percentage of patients who achieved target blood pressure at 6 months, and the secondary outcome was to target BP, the number of patients they reached target BP at 6 weeks and 12 weeks, and change in systolic and diastolic blood pressure at 6 months. And number 3 is whether that patient can tolerate the triple therapy. So these are the results. After 6 months, the triple therapy arm, they achieved 69.5% patients, they were reached the target blood pressure goal, while the usual care group was 55.3%. So 44% increased proportion of patients, they achieved target blood pressure with 3-drug therapy as initial therapy. And what was the secondary outcome? At 6 weeks, 24% more patients, they achieved target blood pressure goal in triple combination arm than the usual care. While at 12 weeks, 25% more patients achieved target BP than the usual care group. And the secondary outcome change in systolic and diastolic blood pressure. You can see the blue in the graph, the blue line for combination group and the yellow line for the usual group. You can see the systolic BP was reduction more in it's 9, almost 9, more than 9, and the diastolic blood pressure, the mean change is 13.9, while whether the usual group was 9.3. So there is change of systolic and diastolic BP at 6 months. And subgroup analysis done, it showed that which patient benefited more. It showed that diabetes patient, they were benefited more. The relative risk reduction in diabetic patients was 1.52, whether the systolic blood pressure who had more than 148 systolic blood pressure and diastolic blood pressure more than 90, more than 85, they showed better outcome in favorable outcome in combination TIL therapy. So this study favored triple combination therapy in diabetic patients, and the baseline blood pressure is systolic blood pressure more than 148, diastolic blood pressure more than 85. That is an important observation. So conclusion of TRAM study, there is increased proportion of hypertensive patients with blood pressure targets, more reduction in systolic and diastolic blood pressure. Diabetic patients benefited more, and more beneficial in patients with higher baseline BP, more than 148 systolic and 85 diastolic blood pressure. And all the patients, like patients are well tolerated, and there are some adverse effects like headache, dizziness, edema, and hypotension. Not so significant. So I have Temisartan Amlodipine Chlorthalidone is most effective combination for a triple therapy. So the indications, I will not go into details. You all know that I already mentioned for the treatment of hypertension, especially when the patient is not responding to dual hypertensive therapy. You can try the triple hypertensive therapy. Dose is 1 tablet to be taken orally. Next slide, please. Blood pressure may be prescribed blood pressure uncontrolled on dual therapy, BP with comorbid disease like diabetes, BP with high CV risk, blood pressure more than 150/90 as initial or escalation therapy. And these special populations, usage of pregnancy and lactation not investigated, so not recommended. Pediatric population not investigated less than 18 years of age. Geriatric populations, decreased clearance of amlodipine in elderly, therefore a lower initial dose of amlodipine may be required. Next slide, please. So the summary. Before going to summary, you have to keep in mind that starting triple therapy, you have to monitor the patient very carefully, because elderly, frail patient, if you reduce too much blood pressure, if the systolic blood pressure is less than 120, then there is increased cardiovascular mortality. So you have to be very cautious about that. You have to check blood pressure regularly, and you have to advise patients for home monitoring of blood pressure. That is very important. So summary and conclusion. ESC guidelines recommended ARB, calcium channel blocker, and diuretic as the ideal combination. Temisartan Amlodipine Chlorthalidone is a good combination. So clinical experience of component drug, CV outcome trials, efficacy proven by TRAM trials. So thank you very much. Thank you very much for patiently listening to me.
Thank you. Thank you, Dr. Naskar. You have elaborately and nicely covered the topic, starting from definition of blood pressure, pathogenesis, organ involved, then neuroendocrine mechanisms behind hypertension, pathogenesis, and rationale of choosing different drugs, the pros and cons of monotherapy vis-a-vis the multiple drug therapy, and especially highlighted the importance of single pill combination as suggested from different guidelines and all. So it is well covered. Now
Thank you
Is
very
there
much.
any
Thank you very
question?
much.
I got one question from Dr. Naresh Singhal from Jamshedpur. I should take up the question first, though not directly related to the topic per se. That does labile hypertension need to be treated?
Sorry?
Does labile hypertension need to be treated?
Labile hypertension. Okay, actually, we have to.
From Dr. Naresh Singhal from Jamshedpur.
Yeah, actually, the labile hypertension, we have to monitor the patient very carefully. I've already mentioned that ambulatory blood pressure monitoring and home blood pressure monitoring should be strongly suggested. And we have to. I've already mentioned that in ambulatory blood pressure monitoring, you have to take the 14 readings at least and average the blood pressure. And the patient, if there is like the blood pressure fluctuation, we have to monitor properly. If the patient has underlying cardiovascular, like there is risk factors for cardiovascular disease, I've already mentioned that what are the predisposing factors for CV disease. Also, the lifestyle, the smoking habit, the family history of premature cardiac disease. So you have to keep in mind all the things. So we have to be more.
So I think you mean that if there is hypertension, labile hypertension patients are associated with evidence of hypertension mediated organ damage, then we should be more keen or more likely the patient will be treated, but better evaluation is mandated before starting treatment.
Yes.
Okay, Dr. Konar, do you want to ask any question?
No, sir, no questions from my side. Thank you.
Okay, thank you.
Arita, Dr. Okay. Then another just for discussion that Dr. Naskar, regarding use of, hello?
Yes, I can hear you.
Can you hear me?
Yeah, I can hear you. Yes, I can hear you.
Combination drug therapy, there are number of pros in favor of single pill combination, but there are some cons too. Can you elaborate one or two?
Yeah, actually, exactly. The main concern is the side effects. Suppose a patient is having hyponatremia, hypokalemia, in the combination therapy, then if there is a single pill therapy, then there is a combination of calcium channel blockers. So if there is a specific therapy related adverse effects, we cannot change the therapy. So we have to be very cautious. Suppose the patient is having flexibility. So the flexibility is less. So the flexibility is less, and also suppose the adverse effect, like if there is calcium channel blocker related effects like bipedal soiling or something, so the flexibility is less. So we have to be keep in mind in that. So different.
Okay. We have nice discussion on topic of hypertension and the combination therapy, particularly triple drug therapy, particularly in single pill combinations that we have learned a lot. Now we can switch over to the other topic, more related to the interventional aspect of cardiology. And we have with us Dr. Arita Konar, who is very close to my heart. We worked together in Arjikar for a lot of time, and now he is really shining in the field of cardiology and budding star, we can tell. And we expect a lot from him in future too. And for this evening, he is going to highlight the different facets of antiplatelet therapy in the arena of percutaneous coronary intervention. Dr. Arita Konar, please.
Thank you, sir. Good evening, everyone. It's a pleasure to meet you all tonight, especially Professor Dr. Bhadury and Dr. Arindam Naskar. Actually, I want to correct, sir, because we did not work together. Actually, I was a student, precisely, because during MD at Arjikar, I actually learned a lot from sir during different academic discussions, and I am really thankful for that. And I also want to express my sincere thanks to all the personnel from Ipca Pharmaceuticals, particularly Debayan, Tina, Om Prakash, and any other personal if is there present tonight. Okay. So Shubho Sharodia, Shabaike. Let me start with the topic tonight. So I'll be discussing on antiplatelets in PCI. So to start with, ischemic heart disease, we know this is a leading cause of death among the all cardiovascular deaths. If we consider globally or in India, whatever we consider it, it is the leading cause of death. I'm not going into statistics, but we have to deal with this every now and then, and every cardiologist and every also for the medicine practitioners, we get ischemic heart disease, and we need to have a clear and brief mindset and guideline regarding the treatment protocol for the ischemic heart disease. Next. So most deadly of the all ischemic heart disease are the acute coronary syndrome. May it be ST elevation MI or non-ST elevation MI or unstable angina. Whatever the acute coronary syndrome presentation is, there is a sudden impairment of blood flow to the heart muscle, and that damages the heart muscle to some extent, and the heart muscle tissue dies if a patient comes to us very late. So we have to deal it very fast and to start the therapy as fast as possible. Next. If we look at the overview of acute coronary syndrome diagnosis and management, in any suspected acute coronary syndrome patient, if we get a hint from a 12-lead ECG, and if we do the clinical assessment like the presence of chest pain and biomarker elevation and all, we can divide the syndrome into two parts. One is the ST elevation MI or the non-ST elevation MI or unstable angina. And if the patient comes directly to we know that if the patient comes directly to any big center where cath lab is available, then in ST elevation MI, we definitely have to go for primary PCI, no other way. But in the patients of non-ST elevation MI or unstable angina, in this group of patients, there are scope for medical management initially, and preferably PCI to be done in this group of patients within 72 hours of presentation. Next. So coming to the antiplatelet therapy, which is the topic of discussion for me today. Antiplatelet therapy is a primary therapy in the ACS management. It's an essential tool which reduces the risk of developing clinically apparent atherothrombosis, and also it's a mainstay of therapy in patients who have established cardiovascular disease, cerebrovascular disease, and peripheral arterial disease. Next. So we have a lot of different groups of antiplatelet agents. The most importantly, and which is an historic agent which was used from the very beginning and still being used rampantly, is the COX-1 inhibitor, that is aspirin. And the another group which has a vital role in the coronary artery disease management is the P2Y12 receptor antagonist, that is the clopidogrel, prasugrel, and ticagrelor. There are other agents, but these are the most important three agents which we commonly use. But clopidogrel and prasugrel, the mechanism of action is a little bit different from the ticagrelor. I will come to that later. And there are other antiplatelet agents also, like intravenous agents, which is called GP2B3A blockers, which are particularly used in the setting of percutaneous coronary intervention during angioplasty. Next. Okay, so if we compare different agents, there are detailed pharmacodynamics and pharmacokinetics. I am not going into detail, but to mention is that ticagrelor is an antiplatelet P2Y12 receptor antagonist, which is reversible and it acts directly. This is not a prodrug, but clopidogrel and prasugrel, these two drugs are prodrug, and these are irreversible P2Y12 receptor antagonists. And ticagrelor has an advantage. What is that? It has a fast onset and fast offset of action. So we can discontinue, and if we need, if a patient is on ticagrelor and we need to perform a surgery in the patient, so less time for discontinuation can be allowed for ticagrelor, because we can stop for 3 days or to 4 days and then we can proceed for the surgery, which is not possible for the clopidogrel and prasugrel, because in those group of drugs the offset is not that faster. Next. Okay, evolution. Okay, so if we look at the history, look back at the history of antiplatelet therapy, the age-old drug is the aspirin, which came after the ISIS trial actually at 1988, and from that time it is the mainstay of ischemic heart disease management, and till now, after 30 years of coming into the field of cardiology, it is still the most important drug in the management of ischemic heart disease. Then after the next decade came other trials like a pre-cure. These are all trials considering clopidogrel, and clopidogrel, the cure trial was a landmark trial in 2001, which showed that addition to clopidogrel with aspirin was much more efficacious, and it resulted in 2% reduction in the risk of cardiovascular further events if compared to the aspirin alone. So from after 2001 and the first decade of the 21st century, then the aspirin plus clopidogrel combination therapy has been evolved as the mainstay of therapy after stenting, after angioplasty. Then came the prasugrel trials like Triton-Timi 38 at 2007, and prasugrel trial, this Triton-Timi trial showed that prasugrel is much better efficacy, has a superior efficacy compared to clopidogrel, but the bleeding risk was higher. So prasugrel was after that, prasugrel was recommended in PCI patients, but only PCI patients, not in the non-PCI patients, because there was no such confirmed data on non-PCI patients for the use of prasugrel. And also prasugrel use has clear-cut contraindications because it has a high bleeding risk. I'm coming to that later. Next. Then the landmark trial Plato of the ticagrelor. This trial showed first time that ticagrelor reduced rate of CV death, MI, stroke, all-cause mortality, everything at 12 months in comparison with clopidogrel. Plato trial actually showed that aspirin plus ticagrelor combination was superior than aspirin plus clopidogrel combination in prevention of the cardiovascular death, MI, or stroke, but there was no significant increase in the measured beat. There are a lot of trials. I'm not going into detail. Next. Coming to the DAPT therapy for management of acute coronary syndrome. Next. Okay, so what are the role of the dual antiplatelet therapy in acute coronary syndrome? Antiplatelet therapy is the mainstay, obviously is the mainstay of treatment and secondary prevention of acute coronary syndrome, and it results in incremental reduction in the risk of thrombotic event, further thrombotic event reduction, MI reduction, stroke reduction, all are good, all are done, achieved by the use of DAPT, whether PCI is done or not in every acute coronary syndrome patients. Next. Pharmacological properties I have already discussed. This is a repetition of slide. Next. So to discuss little bit pros and cons of different agents. If we think of ticagrelor is an agent, because of its superior efficacy, we use now and then almost in every PCI patients in our setup at least. So the pros and cons, if we discuss, the advantages are it has a rapid and extensive platelet inhibition. It has a reversible inhibition and rapid offset of action. What I have already mentioned, for surgical patients, if we want to do surgery, we can stop for 3 days and do surgery in the patient. And bleeding risk is overall similar almost to the clopidogrel if compared to the clopidogrel, and reduction in ischemic event rate is good, better than clopidogrel. But what are the disadvantages? It is expensive. Obviously, it is much more expensive than clopidogrel. The dosing is twice daily. In every medicine, if the patient has to take once daily dosing, there the compliance is much better. And then another problem is dyspnea. Some patients, after starting off ticagrelor, may develop some dyspnea, some shortness of breath. But in most of the patients, if we counsel well and the drug is continued for maybe 1 or 2 weeks, then they can adjust to the dyspnea, and ultimately they doesn't perceive the dyspnea at all. But in some of the patients, they cannot tolerate it for the dyspnea, then we have to continue, we have to stop the medicine and we have to switch to other agent like clopidogrel. Next. So the pros and cons of prasugrel, we were discussing that prasugrel is a good efficacy and it has a once daily dosing, but the disadvantages are it is expensive, bleeding risk is high, so it is not used in the elderly people, particularly in the age group of more than 75. It is not used. We have to look at the body weight, also less than 60 kg body weight we do not use. And in every patient who has a history of CVA or TIA, transient ischemic attack, we do not use prasugrel because it has a significant higher bleeding risk. And also in non-PCI patients, in acute coronary syndrome, in the patients where PCI has not been done, there is no such good data and controlled trials, randomized controlled trials to suggest the use of prasugrel. So we don't use in those subset of patients. Next, clopidogrel. Well, clopidogrel is used for a long time, and it is an affordable price, long history of use. Dosing is also once daily dosing, but disadvantages are it has a susceptibility to genetic variation and drug-to-drug interactions. So sometimes there is intolerability or different drug-to-drug interactions, so we have to stop it and we have to switch to other drugs. And response variability is also there, and it is not a disadvantage, but if we compare to the other two drugs, then it is less efficacious than ticagrelor. Next. So coming to the guideline recommendations for DAPT. Next. What does the 2016 SCCHA guideline says? So if we look at the treatment algorithm in any recent acute coronary syndrome patient, depending upon the management strategy, their duration of the dual antiplatelet therapy and use of clopidogrel or ticagrelor, it varies. Like if we do PCI, whether it is BMS or DES, in acute coronary syndrome patient, if PCI is done, then at least 12 months of dual antiplatelet therapy to be given. And if the patient is on medical therapy, then at least 12 months of therapy, single drug can be given. And in the bypass surgery also, dual antiplatelet therapy of 1 year to be given. After that, bleeding risk has to be determined. High bleeding risk is there or not. If high bleeding risk is not there, then more than 12 months we can continue a single antiplatelet therapy. In some indications we can do dual antiplatelet. I am coming to that later. Next. Treatment algorithm for duration of and P2Y12 inhibitor therapy in patients treated with PCI. So it is almost the same slide repetition. Next slide. So what are the class 1 indications and recommendations for DAPT? In patients with acute coronary syndrome treated with DAPT after BMS or DES, a P2Y12 inhibitor therapy, whether clopidogrel or prasugrel or ticagrelor, should be given for at least 12 months. And another class 1 indication is in patients treated with DAPT, a daily aspirin dose of 81 mg, the ranging from 75 mg to 100 mg is recommended. Next. Now then came the 2017 ESC focused update on DAPT use. So there is little difference between this 2017 ESC focused update and the prior 2016 guideline. What is that? Next. Next. Yes. So here the 2017, no. Show the previous one. Yes, keep that. So the focused update 2017 ESC guideline, it says that in patients with acute coronary syndrome, ticagrelor 180 mg loading followed by 90 mg twice daily. Ticagrelor on top of aspirin is recommended, regardless of initial treatment strategy, including patients pre-treated with clopidogrel. That is the class 1 indication. So this guideline, the focused update 2017 ESC guideline, it gives a superior place for the ticagrelor along with aspirin, and it is not preferring clopidogrel as the first agent. And another class 1 indication is in patients with ACS undergoing PCI, prasugrel 60 mg loading dose followed by 10 mg once daily dose on top of aspirin is recommended with NSTE-ACS or initially conservatively managed STEMI if indication for PCI is established. another last class 1 indication is there. Pre-treatment with P2Y12 inhibitor is generally recommended in patients in whom coronary anatomy is known, and the decision to proceed to PCI is made, as well as in patients with STEMI. So this new guideline, the new focus update tell us that ticagrelor along with aspirin is preferred over clopidogrel in the patients of acute coronary syndrome who are undergoing PCI, and also prasugrel may be preferred along with aspirin over clopidogrel in the PCI patients after coronary anatomy is known. Next, DLPT duration in ACS patients treated with PCI is that, again, it is almost similar. In patients with ACS treated with coronary stent, DLPT with P2Y12 inhibitor on top of aspirin is recommended for 12 months unless there are contraindications such as excessive risk of bleeding. And they have calculated some scoring, that is the precise DLPT scoring with a score calculator. And if it is more than 25, that means there is excessive risk of bleeding. Then sometimes the second agent, that is the P2Y12 inhibitor, might be stopped after 6 months, but preferably should be both drugs should be continued for at least 12 months. Next. Now, if we want to minimize the bleeding risk, there is one factor. There is a recommendation in the guideline that radial access over femoral access is recommended for coronary angiography and PCI if performed by an expert radial operator. Yes, if the operator is expert, he has done a lot of radial cases, then only radial access is preferred over femoral to reduce the bleeding. And in patients treated with DAPT, a daily aspirin dose should be kept between 75 to 100 milligram. A lot of people prescribe 150 milligram of aspirin. That is not needed, that is not recommended. 75 to 100 milligram aspirin, precisely 75 milligram of aspirin in our in Indian setup, Indian body weight, people body weight is enough for that. And PPI, one proton pump inhibitor, anything is in combination with DAPT is recommended always for long-term dual antiplatelet therapy. Next. What is the duration for discontinuation of dual antiplatelet therapy for patients undergoing elective surgery, non-cardiac surgery? I was telling before that ticagrelor, we can minimize the discontinuation by using ticagrelor, but that we can stop it just 3 days prior to the surgery. But for clopidogrel, we have to stop it 5 days before surgery, and prasugrel has the longest offset of action, so we have to stop 7 days prior to surgery. But if we consider this aspect to do this elective surgeries, non-cardiac elective surgeries, ticagrelor has a much more advantage over the other drugs. Next. Algorithm for switching between these antiplatelets. Sometimes the clopidogrel is not tolerated, having some drug-to-drug interactions. Ticagrelor might cause dyspnea in some of the patients. So we sometimes need to switch the therapies. So there are some recommendations regarding the switching of therapy, but in acute setting, if the patient is having ACS, just recent acute coronary syndrome is there, if we need to switch the P2Y12 receptor antagonist, then we have to always reload the agent. That means if the patient was on clopidogrel and we need to shift to ticagrelor, then we have to load the ticagrelor with 180 milligram after 24 hours after the last dose of clopidogrel, then to continue as a maintenance therapy. Or if the patient was on ticagrelor, we want to shift to clopidogrel, then we have to load with 600 milligram of clopidogrel after 24 hours of the last dose of ticagrelor, and then continue 75 milligram once daily. That is to be done. But in chronic setting, if we want to switch the clopidogrel, we might not need to load the agents. We might just after the 24 hour after the last dose, we can continue the maintenance dose. Next. So coming to another guideline, 2018 CCS, Canadian Cardiovascular Society guideline. What does it say? Next. Yes. So if the PCI is done for STEMI or non-ST elevation MI, dual antiplatelet for 1 year is a mandatory. Aspirin 81 milligram daily plus preferably ticagrelor 90 twice daily or prasugrel 10 milligram daily. That is preferred over clopidogrel 75 milligram daily. After 1 year, we have to determine the bleeding risk. If the patient has high risk of bleeding, continue single antiplatelet therapy, that is aspirin 81 milligram daily or clopidogrel. But if the patient does not have any high risk of bleeding, we might continue dual antiplatelet for up to 3 years. And how to continue? Aspirin 81 milligram daily plus ticagrelor in a lower dose, 60 milligram twice daily. It has come from a trial, that is the Pegasus trial. I am coming to that later. That trial results suggested that lower dose of ticagrelor after 1 year of BAPT, lower dose of ticagrelor continuation along with aspirin might have a very beneficial effects. Next. Now, in the elective PCI, what does the Canadian Cardiovascular Society guideline says in the elective PCI? In the elective PCI, if there is high risk of bleeding, then DAPT for 1 month if BMS or 3 months if DAS. Forget BMS, we do not use BMS. So at least 3 months of dual antiplatelet to be given. After that, we can shift to single antiplatelet therapy. In elective PCI, in stable angina, most of the patients, no acute coronary syndrome. And if the patient is not at high risk of bleeding, then at least 6 months of DAPT is mandatory. Preferably aspirin plus clopidogrel. And after that, if there is presence of high risk clinical and angiographic features for thrombotic events, then continue extended DAPT up to 3 years. And if it is not there, then single antiplatelet to be continued. So depending upon the risk of bleeding, whether it is high risk bleeding or low risk bleeding, we can decide the therapy of dual antiplatelet duration in the elective PCI group. Next. Recommendation for patients with atrial fibrillation. Now, this is a specific subset of patients, atrial fibrillation with acute coronary syndrome. Now, we know if the patient is having atrial fibrillation and having CHA2DS2-VASc score more than 1, more than equal to 1, we have to give some oral anticoagulation. We know that. But now, if this patient is complicated by acute coronary syndrome, what to do? Now, the patient has AF, the patient has developed acute coronary syndrome, and we have done PCI. Now what? Now first first this page shows that atrial fibrillation and elective PCI, no acute coronary syndrome. So what to do in the patients of atrial fibrillation and elective PCI is done for stable angina. So we have to look at the age of the patient and CHA2DS2-VASc score. If the age is more than 65, more than equal to, or CHA2DS2-VASc score is more than equal to 1, then the preferred recommended agent should be oral anticoagulant along with clopidogrel. Skip the aspirin. Okay, so oral anticoagulation plus clopidogrel for at least 1 month for BMS and at least 3 months for DAS. After that, just oral anticoagulation continuation might be enough. Sometimes second drug may be added, but only oral anticoagulation continuation may be enough to prevent further thrombotic events. But if the patient's age is less than 65 and CHA2DS2-VASc score is 0, then no oral anticoagulation is recommended. Aspirin along with clopidogrel, this dual antiplatelet therapy to be continued for 3 months for DAS, and after that, only aspirin can be continued indefinite period. Next. Now coming to the atrial fibrillation patient who have developed acute coronary syndrome and the patient has undergone PCI. Now what to do? Again, if we divide this patient into 2 groups, in the elderly group with CHA2DS2-VASc score more than equal to 1, here triple drug is recommended for at least 1 month. That means oral anticoagulant in a minimum dose along with aspirin, along with clopidogrel. These 3 drugs for 1 month to be given. After that, okay, followed by clopidogrel and skip the aspirin, and after that, clopidogrel and oral anticoagulant to be continued. So no, sorry, here it is telling after 6 months. So reduced oral anticoagulant and aspirin plus clopidogrel to be continued for 6 months. After that, skip the aspirin and oral anticoagulation and clopidogrel to be continued for 12 months. And then after 12 months, that means after 1 year of therapy, only anticoagulation is sufficient. Sometimes as the clopidogrel can be added with this. So triple therapy should be given for at least for the first 6 months. And if the patient is younger and CHA2DS2 score is 0, then aspirin along with P2Y12 receptor inhibitor, like not only clopidogrel. We can give ticagrelor and prasugrel or clopidogrel, any agent in this subset, because the bleeding risk, thrombotic risk is lesser, because age is 65, less than 65, and CHA2DS2 score is 0. And dual antiplatelet to be continued for 12 months. After that, aspirin to be continued indefinitely. So the summary is in here is that if the patient is elderly and CHA2DS2 score is high, oral anticoagulation is very important in post-PCI patients. And after a certain time, we can stop the other antiplatelet and oral anticoagulation is to be continued. But if the patient is younger and CHA2DS2 score is 0, then we need not give any oral anticoagulation. We just can give only dual antiplatelet for a certain time. After that, single antiplatelet like aspirin continuation might be enough. Next. So let's look at some clinical evidences, some important trials. There was a registry like antiplatelet treatment in acute coronary syndrome patients, real world data, 1,000 patients. Next. And it was done for 1 year. It showed that with ticagrelor and prasugrel, there was significant reduction in all-cause mortality and cardiovascular mortality. And these two drugs did not increase significantly the incidence of major bleed or minor bleed in comparison to the clopidogrel. Next, PLATO trial. I was telling about PLATO trial. It is regarding ticagrelor. It's a big trial. Almost 18,000, more than 18,000 person was incorporated in the trial, and they were randomized to the patients are of STEMI or non-ST elevation MI, and the patients were randomized to either ticagrelor or clopidogrel along with aspirin. And the primary endpoint which were studied were the cardiovascular death, MI, and stroke. Next, the result was that ticagrelor showed 16% greater risk reduction in CV death, MI, and stroke as compared to clopidogrel at 12 months. So after 12 months of therapy, ticagrelor had a superior effect than clopidogrel to achieve the primary endpoints. Next. And the most important fact is that there was no significant difference in major bleed. That is a very important. So that established the use of ticagrelor in the acute coronary syndrome patients. Next. This is another trial. This is TREAT trial, where the STEMI patients who received fibrinolytic therapy. This is not related to my topic today, but still, STEMI patients who received fibrinolytic therapy, they were randomized to either ticagrelor or clopidogrel, and they were followed up for 12 months. The result was that at 12 months, among the patients with STEMI, efficacy and safety of ticagrelor after fibrinolytic therapy did not differ significantly when compared to clopidogrel. So in this group where PCI is not being done, only fibrinolytic has been given. In this group, the TREAT trial shows that there is no such big difference in use of ticagrelor or clopidogrel. Next. So patients with STEMI treated with fibrinolytic, oh yes, that is the what I was telling in the previous slide. In both the groups, it showed that bleeding events at 30 days and bleeding events at 12 months. It showed that that showed that clopidogrel had a bleeding percentage was little more than the this ticagrelor group. And at 12 months also clopidogrel was measured bleeding was almost similar actually. The columns are not that much different, almost similar incidence of measured bleeding in both groups at 30 days and 12 months. But the efficacy, if we consider, is that there was no much difference. Next. Twilight trial. Twilight trial is a trial which actually it contradicts the usual concept or recommendations of dual antiplatelet therapy, because in Twilight trial it showed that ticagrelor with or without aspirin in high-risk patients, it showed that after 3 months of dual antiplatelet therapy, if we continue ticagrelor without aspirin, there is no much difference in the efficacy if we continue ticagrelor with aspirin. That means omitting aspirin after 3 months of dual antiplatelet therapy and continuing only ticagrelor didn't make much of a difference. Next. It showed that significantly lower bleeding risk was there in ticagrelor alone treated group, obviously because only single drug is being used. And the ischemic event was, the risk of ischemic events were similar in both the group. So this has a contradictory result in the trial, the Twilight trial, that in high risk group of the patients, after 3 months, if the patients were on ticagrelor only instead of ticagrelor plus aspirin, there was lower bleeding risk, but ischemic event also was similar, and there was no increase of ischemic event after stopping of the aspirin. Okay, next. Pegasus-TIMI trial. Okay, Pegasus-TIMI trial is a trial which resulted in different type of spectrum of treatment. From this trial on, there was the starting of use of low dose ticagrelor after 1 year of dual antiplatelet therapy. Next. In this, the trial scheme was that the stable patients with history of MI 1 to 3 years prior. That means there was MI before 1 year, 1 to 3 years, and with one additional atherothrombotic risk factors, like the patient having age more than 65, diabetes, second prior MI, multivessel CAD, and chronic non-end stage renal dysfunctions. In this high risk factor, if one of these factors were there and history of MI 1 to 3 years prior, in this group, they were randomized after 1 year of DAPT, they were randomized to ticagrelor 90 mg twice daily or ticagrelor 60 mg twice daily on placebo. And follow-up visit was done in 1 year and after every 6 months until total 3 years. Primary endpoint seen were CV death, MI or stroke. Next. So the conclusion was that adding ticagrelor to low-dose aspirin in stable patients with history of MI reduced the risk of CV death, MI and stroke. No doubt about that. Ticagrelor increased the risk of TIMI major bleed, but not any fatal bleeding or ICH. So continuing ticagrelor for at least 3 years, if we do that, it increases the risk of TIMI major bleed, but no fatal bleed or intracranial hemorrhage. And if we compare the two doses, 60 mg twice daily and 90 mg twice daily, if we compare these two doses, these two ticagrelor doses had similar overall efficacy. It showed similar efficacy, but the bleeding was much lesser in the 60 mg twice daily group. So why not use this 60 mg twice daily dose of ticagrelor along with aspirin for at least 3 years, and we get some benefit, but the bleeding risk does not increase much. So that was the conclusion of this Pegasus trial, and from this trial on, the latest guideline, that Canadian Cardiovascular Society guideline also, and the 2018 guideline also, they have recommended that in high risk of the patients, we can continue ticagrelor 60 mg twice daily along with aspirin after this 1 year of dual antiplatelet therapy. Next. So coming to the end of the presentation, if we recap the key points related to the antiplatelets, is that addition of clopidogrel to aspirin is a cornerstone of management from the historic era in the patient, cornerstone of management in the patients of acute coronary syndrome undergoing PCI. But the novel P2Y12 receptor antagonists like prasugrel, ticagrelor, these agents are much more efficacy than clopidogrel if it is not contraindicated. Increased platelet inhibition is invariably associated with increased bleeding. However, the reversibility of ticagrelor could potentially reduce hemorrhagic complications associated with CABG surgery or PCI. and clopidogrel, not prasugrel or ticagrelor, appears susceptible to a pharmacodynamic responses, and so there are different drug-to-drug interactions. And ongoing investigations of tailored antiplatelet therapy in patients with high on-treatment platelet reactivity will determine whether routine platelet function testing and genetic testing will be useful. Till now, routine platelet function testing and genetic testings are not recommended in all the patients who are getting a long-term antiplatelet therapy. Thank you. Thank you all.
Thank you, Dr. Konar, for an excellent elaboration of several facets of antiplatelet therapy in the setting of ACS needing PCI.
Absolutely.
Now, I first congratulate you for nice conglomeration of data and mentioning about the Canadian guideline, etc. First, I would like to ask you, a question has come from Dr. Shondeep Bunta, Kolkata, that very relevant topic, the question, antiplatelet treatment in a patient of ACS having COVID-19 infection.
So, till now, we are not changing the normal guideline what we recommend. So we are still following the same antiplatelet regime what we were used previously. But since at COVID-19 we are not being able to do PCI in every patient, so we have to rely on the fibrinolytic agents little bit here. In our hospital setup, we after a long time we are using little bit more fibrinolysis lately. But regarding the use of antiplatelet, we are using the same drugs which we're using as per the same recommendations.
Yes, actually in this regard, I would like to mention some data from Italy and US.
Absolutely,
that initially they did good amount of primary PCIs in patients when the rapid antigen test was not available. So regarding the life-saving nature of the PCI treatment, they went for it and kept the patient in isolation and further evaluated and found that patient had COVID-19. In those group of patients, this harmed to some extent the healthcare workers, but not the patients.
Not the patients.
So, not the patients. Patients were equally treated with thrombolytic or primary PCI, and the most importantly, the platelet antiplatelet regimen doesn't differ.
Yes,
and COVID-19 is basically a thrombotic state. So we don't hesitate. We don't hesitate to use the LMWH along with it.
Absolutely. Even low molecular is recommended in COVID.
Or we are using primary PCI. So I think Dr. Runta has got his answer. There's a nice question. Yeah. Now I would like to ask you regarding the use of your active intervention cardiologist and definitely young. So, do you really use DAPT and precise DAPT score in regarding choosing the duration of DAPT?
So, in our practical scenario, I did not use this DAPT scoring system. Actually, the calculated score I did not use, but what we do is that we assess the risk depending upon the clinical spectrum, maybe the age, maybe the presence of bleeding diathesis, kidney disease is there or not, and also the history of CVA is there or not. So I take these points like the age, the kidney disease, the bleeding diathesis, and the history of CVA. I take this up considerations during the continuation of the taking the decisions of continuations of antiplatelet. But to be very frank, sir, even if I have not personally used this ticagrelor low dose along with aspirin more than 1 year of age, 1 year of DAPT. But the data is very strong. Absolutely. Yes.
And what is your take of going to regarding this twilight and other important observations, recent observations that switching to single antiplatelet with ticagrelor beyond 3 months or 6 months in patients with high bleeding risk?
Yes, I think that it requires much more trials to take further decision, because it's too early if we take the twilight trial only consideration, because almost all the guidelines, all the prior showed that dual antiplatelet therapy to be continued for 1 year at least. So after 3 months, only continuing ticagrelor might be a little bit risky. We need more randomized control trial and more data to ensure this type of treatment plan. I think so, sir.
But the bottom line
I'm not comfortable in starting ticagrelor after 3 months of DAPT. Only ticagrelor.
that is the. But bottom line is we should more liberally, where indicated, should use ticagrelor.
Absolutely.
That is
absolutely. Yes.
That is no denying the fact. And one important issue regarding this Canadian and European guidelines, the difference of approach of patients with AF with an oral anticoagulation.
Yes,
Canadian
absolutely.
Too much on this age. This is number one.
Exactly. Yes.
Patient needing oral anticoagulation with high bleeding risk, that part is more detailed, covered in details in ESC guidelines, because these patients on oral anticoagulant undergoing a PCI is always a tricky problem.
Absolutely.
It's a very difficult problem for any physician or cardiologist to deal with.
Absolutely, it's very difficult to deal with. Yes.
Yes, for anybody.
Yes.
So, Aritra, thank you very much for nicely dealing with that topic, and I must and Dr. Naskar for dealing with the different aspects of triple combination therapy. We had a very good evening, academic evening. We met our need satisfied of our academic zeal by two young energetic speakers, and I must thank the organizers, that is from the house of IPCA. We had a very, very effective and fruitful evening as far as academics is concerned. Over to organizers. Thank you very much to everyone. Over to organizers.
Yes, sir. So thank you so much. So on this onset, let me first thank you, Dr. Spandan Bhadury, who has been an excellent moderator for this event, using all the rich experience he has doing this academic event. So thank you so much, sir. And thank you so much, Dr. Arindam Naskar, for touching all the aspects of and scope of triple combination therapy in hypertension management and throwing light through various trials and guidelines. So thank you so much, sir.
Thank you.
And Dr. Konar, sir, thank you so much for giving your insights on antiplatelet therapy use in PCI and even further management. So thank you so much, sir. And last but not the least, let me thank all the doctors or delegates who attended this academic event, taking out time, especially from the Calcutta or West Bengal, where there is a time for Durga Puja. So despite of that, doctors who came here, attended, asked questions. So my sincere thanks to them. So once again, thank you so much, sir, for your valuable time. Thank you so much.